Good afternoon, everybody. It is a pleasure and honor to introduce this lecture for you. Thanks for the organizing committee. Today, I am talking about perioperative echocardiography for anesthesiologists, real practical cases. I work in King Abdullah Medical City, Mecca, Saudi Arabia. I don't have any conflict of interest regarding any of the devices mentioned in that lecture. And I'd like to start by question before we start. Please, by show of hand, how many physicians that are their main practice is anesthesia, and how much of these are practicing perioperative basic transthoracic echocardiography? First case in 2016, King Abdullah Medical City. The patient is 65 years old, female, diabetic, hypertensive, ischemic, and rheumatoid arthritis. This patient was coming for redo hip bioprosthesis surgery. Redo hip prosthesis surgery. There was infectious process there. The event intraoperatively happened is bleeding, hypotension, repeated arrest, and return of spontaneous circulation despite aggressive volume resuscitation. We give volume, how much given? 12 RBCs, fresh frozen plasma, platelets, cryo, and 5 liters of crystalloids and colloids. Not only such a big volume, but also the rate. This rate of volume was given using 2 level 1 rapid infusion machines. And now, at the moment, the question was, is she hypovolemic, hypervolemic, or ischemic? In other words, are we giving too much volume, or are we giving less than we should give, or something else was going on because she is already ischemic? She might have myocardial infarction. This is the transesophageal echo of the patient, the TEE of the patient, demonstrating that this is represent a transverse section in the left ventricle. When you look here at the center of the cavity of the patient here, do you think is it hypovolemic or hypervolemic or something else? And the answer, by looking to the normal heart. If you look at this, represents this video in the left represents the normal heart, and this star in the middle of the left ventricle cavity can, by looking in this star in the right side of the screen, you can appreciate that is a small left ventricle cavity associated with tachycardia. This finding confirmed the diagnosis of hypovolemia. So the decision was more aggressive volume resuscitation was warranted. Call for help from vascular surgeon and the other orthopedic surgeon to come to control the bleeding, and pelvic venous plexus injury was diagnosed. Conclusion from case 1. Despite we have our great expertise in perioperative medicine, in preoperative evaluation and the comorbidities of the patient, in each procedure, specific considerations and the challenges, and even challenges of each surgeon, if we work with him or her for a considerable time, we look very well. We have expertise in medications and monitors and resuscitation. Despite all this perioperative expertise, rescue echo is a very important tool to add to our toolbox in management of hemodynamically unstable patient not responsive to conventional management. So the message from case 1, in 2016, we could say that perioperative rescue echo saves more lives. And in 2024, we can broadly conclude that perioperative point of care ultrasound, BOCUS, and or focused cardiac ultrasound as a part of perioperative BOCUS saves more lives. So the central message is we encourage all anesthesiologists to get expertise in perioperative BOCUS or focus. Revising the last month, 2024 September, American Heart Association guidelines for perioperative cardiovascular management for non-cardiac surgery. In the intraoperative monitoring techniques, in the echocardiography, they are giving a statement of level 2A recommendation. If we have unexplained hemodynamic instability, TEE or focus is reasonable to used if the expertise is available. Note that 2A is, level of recommendation, class of recommendation, is a very strong class of recommendation. Case 2. Case 2 in the pre-anesthesia clinic is a 51 years old female with morbid obesity, body mass index of 48, coming for laparoscopic cholecystectomy. Vital signs are stable. In history and examination, she had chronic mild shortness of breath on exertion. And unremarkable examination apart from questionable murmur. She is morbidly obese. I cannot tell exactly there is murmur or there is no murmur. And now let's think about the decision to clear the patient. In the decision process, I can tell that such a degree of obesity, morbid obesity, could explain this chronic mild shortness of breath on exertion. Oh, according to the guidelines, cardiac for non-cardiac, the European one, 2022, cardiac for non-cardiac, there is no clear indication to do echo for this patient before clearance. Now we left with the decision either to do cardiology consultation to diagnose a subtle cardiac disease, or don't do cardiology consultation, it is unnecessary and may result in unnecessary patient delay. Now, what is your decision? You have expertise in echo. Not only this, you have the handheld ultrasound with you in the clinic. You can see this is a basic handheld echo machine connected wireless to your tablet PC or mobile and can give me a clue to what is happening. Case you decide to put a handheld echo for the patient in the clinic, anesthesia clinic. And for your knowledge, this is the normal parasternal long axis view, at which you see here right ventricle, here left ventricle, mitral valve, left atrium. And in the center, you can see this is the aortic valve in normal patient. By looking to the patient echo, you can appreciate that this aortic valve of the patient is different totally from the aortic valve on the left side of the screen, the normal one. What is the difference? It is calcific, thickened, and not opening well. There is limitation of mobility. So this raises the suspicion of significant aortic valve disease. According to the handheld echo in preclinic anesthesia, we refer for comprehensive echocardiography. Report of echocardiography from cardiology came with severe aortic valve stenosis, bicuspid aortic valve, and patient went for surgical aortic valve replacement. Can we see a patient with severe aortic stenosis with mild or no symptoms? The answer is yes. In the guidelines 2020 American College of Cardiology guidelines for valvular, there are in the stages of aortic stenosis very well-known defined group of patients, stage C1, which is called asymptomatic severe aortic stenosis. By reviewing the guidelines, the European 2022 on cardiovascular management of patients undergoing non-cardiac surgery. Recommendations about transthoracic echo state that focus exam performed by trained specialists may be considered in the pre-operative trial. Another statement in the same guidelines regarding focus, pre-operative focus, or handheld ultrasound, their statement is that focus or handheld ultrasound may impact the patient management by improving diagnostic accuracy of clinical assessment and help to triage candidates for standard transthoracic echo. Case 3. Case 3 is in emergency room, a case of type A aortic dissection for emergent cardiac surgery, referred from another hospital with the CD of the CT scan of the aortic dissection. Patient is 47 years, male, morbidly obese on nasal oxygen, but no echocardiography done yet in our hospital. Surgeon will not wait for the echo and he will shift the patient to OR now, will depend on intraoperative TEE. Now patient is in OR before induction. Before inducing this patient, you might have several inquiries. One, what about gross left ventricle function? Second, is the dissection flap causing severe aortic regurgitation? Is the dissection leaking, causing pericardial effusion or tamponade? And the most important question to think about, if this patient gets hypotensive after induction, what intervention can help better? So we decide to do echo for this patient, transthoracic, rapid quick look. For this is the parasternal long axis, 2D and the color. You can from this view state that the gross normal left ventricle function, no pericardial effusion. And from this color, you can tell there is no severe aortic regurgitation. And confirm this finding also with the transverse section view of the left ventricle to confirm what we saw in the parasternal long axis view. So message from case 3, in many urgent or emergent cardiac or non-cardiac cases, operations, expertise in perioperative focus can lead to better anesthesia plan. Specifically, choice of anesthesia technique, general anesthesia versus regional, choice of anesthesia medication for induction and maintenance, level of monitoring, and the most important, what medication or intervention could help better if hemodynamic instability occurred in that urgent or emergent cardiac patient. Back to guideline, the same guidelines review. You can state that in focus can also impact the plan of surgery and the anesthesia technique with post-operative monitoring. Case 4 and 5. Case 4 is a 5-year-old female child coming for OR for central venous catheter insertion in OR using ultrasound-guided CVB insertion, courtesy to my colleague Dr. Amir Abu Zikri, who had the handheld ultrasound device, and he wants to confirm the correct placement for such a small child of central line. He did handheld transthoracic for him. He put the probe in the subcostal area. What I see here is liver, and here you can see this is right atrium. And saline injection in the central line, you can see bubbles in the right atrium, confirming the correct placement. If you look here, you can appreciate there is gush of bubbles will happen now. Now, as you see, lot of bubbles confirming the correct placement. Even a smaller case, 1-year infant, for the same procedure, you can see here the guide wire of central line insertion in the right atrium, and here you can see the wire and the saline injection. By reviewing the guidelines, practice guidelines for central venous access 2020 by American Society of Anesthesiologists, you can say there is a lot of observational studies confirming transthoracic ultrasound can confirm the guide wire position or catheter tip position. Last case. Last case is 4 days newborn with congenital heart disease. During cath lab correction of his disease or her disease, sudden hypotension and bradycardia during the procedure. Operator said give more inotrope. We put the probe in the subcostal area And now this is what we see. Again, probe in subcostal area. This is the liver. This is the heart. And the two stars, these two stars represents fluid around the heart. Diagnosis of tamponade with immediate pericardiocentesis done. In summary, echocardiography by anesthesiologists saves more lives in perioperative medicine. Expertise in perioperative echo could help in better anesthesia plan and probably better patient outcome. There are many perioperative applications for echo rather than rescue echo. And the sum of this, we encourage all anesthesiologists to get expertise in perioperative point of care ultrasound or focused cardiac ultrasound. And from that point, I invite you all to have a look on the KMC YouTube channel. You can scan the QR code. You will find a lot of videos that can help in basic transthoracic acquisition and optimization and troubleshooting in acquisition. Thank you.